Welcome back to the Explainer, everyone. Today, we are diving straight into the very foundation of our nightly lives. We're going to completely unpack the incredible architecture of sleep, examine exactly what breaks it, and figure out how to fix it, all based on the fascinating medical mechanics of the human brain. We are covering the whole shebang, from the baseline physiology of a normal night's rest, all the way to bizarre stuff like night terrors and sleepwalking. Let's get into it.
All right, here is our roadmap for today. We'll start with part 1, the architecture of sleep. Then move to part 2, what disrupts your rest. After that is part 3, managing and treating insomnia. And we'll wrap up with part 4, navigating bizarre parasomnias. So let's kick things off with section 1, the architecture of sleep, our journey through the night. Now, before we can understand how to fix broken sleep, we really need to define the core problem. And here's the thing. Insomnia isn't just about the number of hours you log with your eyes completely shut. Medically speaking, it's defined as a dissatisfying quantity, or crucially, the quality of sleep that leads to actual daytime dysfunction. So, if the physiological quality of your rest is compromised, you could spend 8 hours in bed and literally still be suffering from insomnia. Okay, picture this. Have you ever been sitting in a quiet room, maybe during a super boring lecture? You start to nod off, and then suddenly, bam, your whole body violently jerks awake. Well, those are called hypnic jerks. They happen in the very first stage of sleep, known as the N1 stage, where your brain is hovering right on that weird boundary between being half awake and half asleep. And honestly, that little jolt perfectly illustrates our progressive descent into rest. As we leave that N1 stage, we drop into N2, which is slightly deeper, and actually where some people experience teeth grinding or bruxism. Then we hit N3. This is the deep, slow wave sleep. It is heavily physically restorative. Your muscles completely relax, and if a fire alarm goes off here, it is incredibly difficult to wake you up. Finally, we reach step 4, REM, or rapid eye movement sleep. It takes a normal, healthy person exactly 90 minutes from the second they fall asleep to hit that first REM cycle. But, the architecture of sleep isn't just static throughout the night. It's more like a seesaw. As the night progresses, the duration of that physically restorative N3 deep sleep actually goes down, while the time you spend in REM sleep keeps increasing. That's exactly why it's so much easier to wake up by the time morning rolls around. Which brings us to the ultimate paradox, REM sleep. If we looked at your brainwaves on a monitor right now, it would literally look like you were wide awake. Your brain is absolutely on fire with activity. This is where memory processing, learning, and those super vivid dreams happen. But, and this is a huge but, for your own safety, your body undergoes something called atonia. Basically, your muscles are temporarily paralyzed so that you don't physically act out sprinting or fighting in your dream. It's built-in survival mechanisms. Moving right along to section 2, what disrupts your rest? We're looking at age, mood, and substances. So here is a really crucial takeaway. A lot of people turn to a nightcap, alcohol, or even benzodiazepines to help them fall asleep. And sure, they will rapidly induce sleep, which totally gives you the illusion that they're helping, but the physiological cost is massive. These substances actively decrease and destroy your N3 deep sleep and your REM sleep. You might be unconscious, yeah, but you absolutely aren't resting. That is exactly why you wake up feeling hungover, foggy, and exhausted the next day. The actual architecture of your sleep was ruined. And it's not just what we ingest. Psychological factors heavily hijack our sleep architecture too. Take a look at how depression alters a night's rest compared to anxiety. With anxiety, a racing mind delays sleep. But someone with depression might actually fall asleep rapidly. The problem is their REM latency shrinks dramatically. They might hit REM in just 10 minutes instead of the normal 90. They get minimal N3 deep sleep, meaning they keep tossing and turning, and classically, they suffer from what's called terminal insomnia, waking up at, say, 4 a.m., hours before the alarm, and they are completely unable to fall back asleep. Which brings us to section 3, managing and treating insomnia. Let's talk about taking back the night. According to the source material, it doesn't matter if your insomnia has lasted for 2 weeks because of a stressful project at work or for 2 years as chronic insomnia. The absolute undeniable first-line treatment is always cognitive behavioral therapy, or CBT. Before any medical professional reaches for a prescription pad, identifying and addressing those underlying psychological stressors is step 1, every single time. And CBT goes hand in hand with rigorous sleep hygiene. We're talking about actively retraining your brain's associations. You need regular bedtimes, cutting out late-day caffeine or alcohol, and, this is a big one, you have to use the bed only for sleep or sex.
stop working or scrolling on your laptop in bed because your brain starts associating that space with stress. And here's a counterintuitive but highly effective trick, the 20-minute rule. If you've been lying in bed for 20 minutes staring at the ceiling, do not watch the clock in a panic. Physically get out of bed, go sit somewhere quiet, and do not get back in until your body actually feels tired. Break the cycle of anxiety.
Now, if behavioral therapies fail, pharmacological help might be the next step, but doctors have to diagnose exactly which type of insomnia you're dealing with because the treatments are entirely different. Sleep onset insomnia, which is often driven by anxiety, means it takes you over 30 minutes to fall asleep, but once you're out, your sleep is totally fine. On the flip side, sleep maintenance insomnia, which is often linked to depression, means you fall asleep easily, but you wake up repeatedly or way too early. So, how do we target those? Well, if you have sleep onset insomnia, the goal is just to get you over that initial hump. First-line targets here are melatonin receptor agonists or sometimes over-the-counter antihistamines. But for sleep maintenance insomnia, doctors will use orexin antagonists. Orexin is basically a compound your brain produces to keep you awake and alert during the day. By blocking it, the brain gets the signal to shut down and, more importantly, stay asleep. And notice what's intentionally missing from these first-line treatments: benzodiazepines. They are heavily avoided because of high addiction risks and the fact that they destroy your deep sleep architecture.
Finally, let's dive into Section 4, Navigating Bizarre Parasomnias. Basically, what happens when sleep goes completely rogue. Let's clear up a massive misconception right now: the difference between nightmares and night terrors. Nightmares happen during REM sleep. Because your body is safely paralyzed in REM, you just lie there, but you vividly remember the terrible dream the next morning. Night terrors, however, happen in the N3 deep sleep phase. And remember, in N3, your muscle tone is active. So a child might sit straight up in bed, scream, and thrash around. It looks absolutely terrifying to a parent. But the huge reassurance here is that the child is deeply, deeply asleep. They will remember absolutely nothing by morning, and generally, no medical treatment is even required. Oh, and a quick side note, for anyone paranoid about what they might be saying at night, relax. Sleep talking is usually just incongruent, random babble. You can rest easy knowing you are definitely not going to accidentally spill all your deep, dark secrets while you snooze. When things actually go wrong in REM sleep, it's a completely different story. In REM sleep behavior disorder, that vital muscle paralysis we talked about earlier, atonia, is completely lost. This means if a patient is fighting off an attacker in their dream, they will physically punch, kick, and thrash right there in their actual bed. Obviously, this is a massive physical risk to their partner. Management involves immediately clearing dangerous objects out of the room and treating the patient. Often this involves melatonin agonists or, in this highly specific case, benzodiazepines to suppress the movement.
So looking at all this incredible, highly active machinery of sleep, we really have to ask, if your brain is truly on fire processing memories and learning during REM sleep, are we ever truly resting? Or are we simply living a second, safely paralyzed life in the dark? It's a pretty wild thought and a fantastic reminder to respect your biology, protect your sleep hygiene, and give your brain the solid foundation it needs. Thanks so much for joining me for this explainer, and I'll catch you next time.